So, the definitions according to WHO and AJC, anal cancer extends from the upper border to the lower border of the internal and external sphincter, that is, the pelvic floor to the anal verge. Anal margin tumors occur outside the anal verge but within 5 to 6 centimeter radius to the anal. Then, canal cancer is 1.5% of GI malignancy, estimated as 3,400 cases per year. Risk factors include female gender, chronic anal irritation, more specifically chronically infected with HPV, anal receptive intercourse, then HIV positive, anogenital warts, history of STDs, increased number of sexual partners, history of cervical, vulvar, vaginal cancer, personal or partner, and immunosuppression, lenient use of corticosteroids or long-term use of corticosteroids, cigarette smokings. Female gender, chronic anal irritation, HPV, anal receptive intercourse, HIV positive, anogenital warts, history of STDs, increased sexual partners, history of cervical, vulvar or vaginal cancer, and immunosuppression, use of corticosteroids and cigarette smoking. All of them causes risk factors. Then 1.5% are estimated for GI malignancies, which is anal cancer, estimated as 3,400 new cases per year. Margin tumor occurs outside the anal verge but within a 4 to 6 centimeter radius to the anus. And anal canal extends from the upper border of the lower to the lower border of the internal and external sphincter, that is, from the pelvic floor to the anal verge. So, anal cancer. Tumor of anal canal tend to be aggressive, non-keratinizing, and associated with HPV infection. Epidermoid, squamous, basaloid, mucoepidermoid, and carcinoma. Symptoms. Prior to diagnosis, there is generally a long history of minor perianal complaints such as bleeding, itching, perianal discomfort, palpable anal mass. All of them will be seen. Signs. At presentation, disease may be extensive with approximate of 1/2 of the lesion extending beyond the bowel wall or perianal skin. Inguinal node metastases are found initially in 15 to 20% of the patient and develop in 10 to 15% over time. Tumors of anal canal tend to be aggressive, non-keratinizing, associated with HPV infection. Epidermoid, squamous, basaloid, mucoepidermoid, carcinoma are the 3 types. Symptoms is prior to diagnosis, it is a long history of minor perianal complaints, bleeding, itching, perianal discomfort, and palpable anal mass. Signs at presentation, disease may be extensive with approximate half of the lesions extending beyond the bowel wall or perianal skin. Inguinal node metastasis found in 15 to 20% of the patient and developed in 10 to 15% of the patient over time. Then, anal margin cancer. Men have a 4-fold increase in risk of anal margin carcinoma. Tumors of anal margin is generally well differentiated, keratinizing tumors that behave similarly to other squamous cell carcinomas of the skin and are treated accordingly. So, anal margin tumors are squamous cell tumors, basal cell carcinoma, Bowen's disease, Paget's disease. Symptoms of squamous cell carcinoma is mass, bleeding, pain, discharge, itching, and tetanus mass. Symptoms, whereas signs are large centrally ulcerated lesions with rolled everted edges, feels hard and woody on palpation. Basal cell carcinoma symptoms are bleeding, itching, and pain. Signs are lesion appears to be raised with irregular edges and central ulceration. Bowen's disease symptoms are perianal burning, itching, or pain. Signs are when grossly apparent, lesions appear scaly, discrete erythematous, and sometimes pigmented. Then Paget's disease symptoms, you have characteristically severe intractable pruritus. On physical examination, an erythematous eczemaoid rash is apparent. So again, squamous cell carcinoma, bleeding, pain, normally everything will be there. Signs have largely centrally ulcerated lesion with rolled everted edges. Okay, and it feels hard and woody on palpation. Basal cell carcinoma, you have bleeding and itching and pain, but lesions will be appearing to be raised with irregular edges and central ulceration. Here the edges will be large centrally ulcerated lesions. With everted edges will be there, but it feels hard and woody on palpation. This does not have that sign. Bowen's disease is perianal burning or itching or pain. It is grossly apparent. Lesions are scaly, discrete, erythematous, sometimes pigmented. Paget's is characteristically severe intractable pruritus. Physical examination, erythematous or erythroid rash is apparent. So, rectal cancer. Its incidence is approximately on 1,35,000. No, that's a weird word. 1,35,000 new case of colorectal cancer. 13,500 new cases of colorectal cancer CRC occur in US. It doesn't matter in US. Third of this in colon, third in rectum. So lifetime risk of developing colorectal malignancy is approximately 5.9% in the general population in US, of course, but these Western countries tend to have a higher incidence than Asian countries, so ours it will be a little bit lesser. I am in Indian. Okay. Then among the religious denominators, CRC occurs more frequently in the Jewish population. Sex. Incidence of colorectal malignancy is higher in males than female. Age. Incidence peaks in 70s. Some cases reported in young children are there. Then, incidence of colorectal malignancy is slightly higher in males than female, whereas anal margin cancer is slightly higher in females than male. Age. Incidence peaks in 70s. Then colorectal cancer etiology. Etiology is unknown, but it appears to be multifactorial in origin. Diet would be high meat, animal fat diet associated with CRC. Then you have high fiber diet protective against CRC. Colorectal cancer. So increased dietary intake of calcium leads to protective effect, and daily alcohol drinkers have twofold increase in risk. Beer consumption more than 15 liters per month is increased risk in male. So colorectal cancer, you have percentage of colorectal cancer according to family risk. Then you have HRCC percentage, hereditary non-polyposis colorectal cancer is 2 to 3%. Most of the cases are sporadic. Some are having familial risk, and FAP also may be there. Hematomatous also might be there. Rectal cancer, a lifetime risk of CRC in first degree relatives of a patient with CRC. You have 1 in 2 first degree relative affected by any age. So population risk is 1 in 50. If the first degree is affected, then it's 1 in first degree relative affected, it's 1 in 17. First degree relative plus second degree relative is affected, it's 1 in 12. One first degree relative affected, which is age less than 45, is 1 in 10. 2 first degree relatives affected is 1 in 6, and autosomal dominant pedigree is seen. Many dominant relatives are affected, then it's 1 in 2. No. Our autosomal dominant pedigree just says that 1 in 2 patients will be having it, not that it's 1 in 2. But yeah, its risk is there. Then rectal cancer. Rectal cancer, it is a genetic disorder, familial adiposis, adenomatous polyposis, which is right over here. FAP is autosomal dominant inherited syndrome that results in the development of more than 100 adenomatous polyps and a variety of extraintestinal manifestation. Defect is in APC gene, which is located on chromosome 5 in the locus Q21. The disease causes the formation of hundreds of intestinal polyps, osteomas of the bone, desmoid tumor, and occasionally brain tumors. Increased number of polyps predisposes patient to a greater risk of cancer. If left untreated, colorectal cancer develops in nearly 100% of these patients of the age 40. While the hereditary risk is documented, approximately 20% of FAP are caused by spontaneous mutation. Hereditary non-polyposis colorectal cancer (HNPCC), autosomal inherited syndrome that occurs because of defective mismatch repair genes located on 2, 3, and 7. Patients have the same number of polyps as the general population, but their polyps are more likely to become malignant. These patients also have higher incidence of endometrial, gastric, thyroid, and brain cancers. Then you have Amsterdam criteria for HNPCC. 3 plus cases of CRC is in minimum of 2 generations. One affected individual must be a first degree relative of the other 2 plus cases. One case must be diagnosed at the age less than 50. CRC can be replaced by endometrial or small bowel cancer. FAP should be excluded. So, hereditary non-polyposis colorectal cancer. But yeah, they will also be having number of cancers, but their polyps are more likely to become malignant. They have higher incidence of endometrial, gastric, thyroid, and brain cancers. Amsterdam criteria is for HNPCC. 3 plus cases of colorectal cancer in 2 generations. One affected individual must be a first degree relative of the other 2 plus cases. Then one case must be diagnosed at the age of less than 50, and CRC can be replaced by endometrial or small bowel cancer. FAP should be excluded. For then you have inflammatory bowel diseases, as they also predispose. Ulcerative colitis, incidence of malignancy increases with duration. After 10 years, the incidence of colorectal cancer in ulcerative colitis is approximately 1% per year. Crohn's disease. Incidence of CRC in patients with Crohn's disease is 4 to 20 times greater than that of the general population. Cancer occurs in patients with disease of at least 10 years duration. Average age at diagnosis, that is 46 to 55, is younger than that of the general population. Cancers often develop in areas of strictures and defunctionalized segments of the intestine. In patients with perianal Crohn's disease, malignancy often presents as a fistulous tract. In patients with Crohn's colitis, undergo the same surveillance regimen as those with ulcerative colitis. Surveillance should be there. Then, rectal cancer symptoms. It is very important to take complete history from the patient, including a family history and assessment of risk factors for developing rectal cancer. Many rectal cancer produces no symptoms and are discovered during digital or proctoscopic screening examinations. Then, rectal cancer symptoms. You have bleeding 60%, change in bowel habits 43%, occult bleeding in 26%, abdominal pain in 20%. Others you have malaise in 9%, bowel obstruction in 9%, pelvic pain in 5%, peritonitis from perforation in 3%, and liver metastasis in 1%. Then rectal cancer symptoms. Bleeding is there, often attributed to other causes. Example, hemorrhoids, especially if the patient has a history. Then of course the bleeding will be profuse and anemia is rare, and it may be accompanied by passage of mucus and warrant further investigation. Bleeding occurs in 60% of the cases. And then change in bowel habit occurs in the form of diarrhea, particularly if the tumor has a large villous component. Some patients experience a change in the caliber of the stool. Large stools can cause obstructive symptoms. Tumors located in the rectum can cause a feeling of incomplete evacuation and tenesmus. So this occurs in 43% of the cases. Occult bleeding. Occult bleeding is done. Abdominal pain, partially large bowel obstruction may cause colicky abdominal pain and bloating. Back pain is usually a late sign caused by tumor invading or compressing nerve trunks. Urinary symptoms may occur if the tumor is invading or compressing the bladder or prostate. Then, in rectal cancer signs, physical examination is performed with a specific attention to possible metastatic lesions, including enlarged lymph nodes or hepatomegaly. Digital rectal examination, you have the average finger can reach approximately 8 cm above the dentate line. The tumors can be assessed for size, ulceration, and presence of any pararectal lymph nodes. Fixation of the tumor to the surrounding structures, example sphincters, prostate, vagina, can also be assessed. Digital rectal examination also permits cursory evaluation of the patient's sphincter function. This information is necessary when determining whether a patient is a candidate for sphincter sparing procedure. Cursory evaluation of patient's sphincter function. Okay, and these are the list of resources again. So for revision, let us open another slide and just try to remember whatever we have read. So anatomy. So internal anal sphincter, external anal sphincter should be remembered. All the anal slings and all can be asked. And yes, anal and perianal, margin cancer also can be asked. So clinical anatomy, it is 15 to 25 centimeter from anal wards. Diameter is 4 centimeter in upper part and dilated in the lower part. Posterior part of the lesser pelvis and in front of the lower 3 pieces of scrotum and coccyx will be present. It begins at the rectosigmoid junction at the level of third sacral vertebra. It ends in the anorectal junction 2 to 3 centimeter in front of and little bit below the coccyx. Begins at the rectosigmoid junction at the level of third sacral vertebra. Ends at the anorectal junction 2 to 3 centimeter in front of and little below the coccyx. It ends at the anorectal junction 1 to 3 centimeter below front of and a little bit below the coccyx. The rectum is divided into 3 parts: the upper third, the middle third, and the lower third. 3 distinct intraluminal curves, walls of Houston, will be there. Left upper wall of Houston, right middle wall of Houston, left lower wall of Houston, left, right, left. Peritoneal relation. The superior third of the rectum is covered by the peritoneum on the anterior and lateral sides. Middle third of the rectum is covered by the peritoneum on the anterior surface. Inferior third of the rectum is devoid of peritoneum and lie close proximity to the adjacent structures including bony pelvis. Note: distal rectal tumors have no serosal barrier to the invasion of adjacent structures and are more difficult to resect given the close confines of the deep pelvis. This has better anatomy, I feel. Okay. Arterial supply is inferior mediastinal artery supplies the upper and middle rectum. Middle rectal artery, superior rectal artery from inferior mesenteric artery supplies upper and middle rectum. Middle rectal artery from the internal iliac artery supplies the lower rectum. Inferior rectal artery from internal pudendal artery. Venous drainage. Superior rectal vein is upper and middle third of the rectum. Middle rectal vein is lower rectum and upper anal canal. Inferior rectal vein is for lower anal canal. Innervation. Sympathetic is L1, L2, L3 and hypogastric nerve. Parasympathetic is S22 to S24. Then lymphatic drainage is upper and middle rectum. You have pararectal lymph nodes located directly on the muscle layer of the rectum, and you also have inferior mesenteric lymph nodes via the nodes along the superior rectal vessels. Lower rectum, you have sacral group of lymph nodes or internal iliac lymph nodes. Then finally, below the dentate line, you have inguinal nodes and external iliac chain. Upper and middle rectum, pararectal lymph nodes, inferior mesenteric lymph nodes. Lower rectum, sacral group of lymph nodes or internal iliac lymph nodes. Below the dentate line, inval lymph nodes and external iliac child. Epidemiology. Colorectal cancer is the third most frequently diagnosed cancer in the US men and women. Around a lakh new cases of colon cancer and 40,000 new cases of rectal cancer in US only. Combined is for 50,000. Worldwide, 1 million cases, and incidence in India is quite low, which is about 2 to 8% in 100,000. Median age is 7 decades, but it can occur in adulthood also. Okay. Okay. Cecum is 14 to 10% of the cases, cancer cases. Ascending colon is 10% cancer case, transverse colon is 12%, descending is 7%, sigmoid colon is 25%, rectosigmoid junction is junction itself is 1%, and rectum is 23%. Etiological agents have first of all environment and dietary factors, chemical carcinogens. Associated risk factors: male sex, family history of colorectal cancer, personal history of anorectal cancer, ovary, endometrial breast, excessive BMI, processed meat intake, excessive alcohol intake, low folate consumption, and neoplastic polyps. Hereditary conditions such as FAP and HNPCC. Familial adenopolyposis. Hereditary non-polypoid colorectal cancer. For rectal cancer, male sex is more. History of colorectal is there. Personal history of colorectal cancer, ovarian, endometrial or breast cancer. Excessive fat person, processed meat intake, yes. Less folate consumption, excessive alcohol, neoplastic polyps. Etiology and environment, that and environment factor and chemical carcinogens. Yes. Clinical presentation: you have bleeding, occult bleeding, then abdominal pain, and what was the other thing? I'm not remembering. Change in bowel diabetes, diarrhea, constipation, narrow stool. They may also be symptomatic. The rectum, abdominal distension, weight loss, and tiredness. Discomfort. Acute presentation: you have intestinal obstruction, so colic pain will be there, perforation may be there, and massive bleeding is there. So signs in the clinical presentation: pallor will be there, abdominal mass will be there, PR, post-rectal mass will be there, jaundice will be there, and nodular liver and ascites will also be there. Rectal metastasis is travel along the portal drainage to the liver via superior rectal vein, as well as systemic drainage to lung via middle inferior rectal veins. Repeat rectal metastasis travel along portal drainage to liver via superior rectal vein, as well as symptomatic drainage to the liver via systemic drainage to the liver, lung via middle inferior rectal vein. Pathological features: WHO classification, adenocarcinoma in situ, adenocarcinoma, mucinous squamous adenocarcinoma, sigmoid carcinoma, squamous carcinoma, adenosquamous carcinoma, small cell wart cell carcinoma, medullary carcinoma, undifferentiated carcinoma. Mm.